lesion that can simulate choroidal melanoma. Please start.
Thank you very much. So today we'll talk about the lesion that can simulate choroidal melanoma. From the large study from the Shields, studied almost 1,800 pseudomelanomas. Choroidal nevus is the most common lesion that can simulate melanoma. Our series, we have 147 pseudomelanoma referred to us. Choroidal nevus is the most common as well, followed by the same diseases, but maybe the ranking is different. So nevus is very common in white population, and the risk of malignant transformation is very low. In Chinese population, they follow the nevi for 5 years, and then none of them show malignancy change. So what are the risk factors for malignant transformation, and why we need to know it? Because each millimeters of the increasing in melanoma, the more likely that the patient would have the metastatic disease. So if we detect the melanoma earlier, then we can treat it, and the treatment outcome would be better. So the mnemonic is very helpful and easy to remember. To find small ocular melanoma using helpful hints daily. Whereas the T is the thickness more than 2 millimeters, F is the subretinal fluid, S is the symptoms, O, orange pigment presents on the tumor, margin of the tumor close to the optic nerve, ultrasound hollowness, halo absence, and drusen absence. So these two patients, one has nevus and one has melanoma. Which one is which? So from the clinical picture, you can see that the fluid, very carefully, you can see that the fluid is around both tumor. Both patients have symptoms, decreased vision due to the subretinal fluid involving the foveola. The patient on your right has orange pigment, and the patient on your left has drusen. The margin on the right is close to the optic nerve. The one on the left is away from the optic nerve. You don't see halo in both patients. From the ultrasound, both patients has tumor thicker more than 2 millimeters, but only one on the right has hollowness. Sometimes fundus autofluorescence and OCT can help you to detect orange pigment as the very bright autofluorescence over here, minimal autofluorescence by subretinal fluid. And by OCT, you can detect the subretinal fluid and also the subretinal orange pigment on melanoma. So in both patients, now we know that the patient on the right is melanoma and on the left is the nevus by those risk factors. So remember it well to find small ocular melanoma using helpful hints daily. So other features on EDI-OCT has been shown to differentiate choroidal nevus from melanoma. The shaggy photoreceptors is the swelling of the photoreceptors due to recent subretinal fluid. And also the subretinal lipofuscin is the orange pigment that you can see in melanoma patients. Comparing in both nevus and melanoma, these three features are highly significant in melanoma other than choroidal nevus. Sherpy is the second most common in our case series. It's a flat pigmented lesion, very sharp margin, and if you do the fundus autofluorescence, it's completely black, totally different from melanoma. Sometimes they can have the lacuna inside the tumor, and it shows flat on ultrasound. Blockage on FA and ICG, and if you do the OCT, you can see the thickening of the RPE, loss of photoreceptors overlying RPE thickening, and in area of lacuna, you can find the RPE atrophy. So the studies, very large series, see the Sherpy, and then they found that this lesion can be enlarged in over 83%, but very slowly enlargement, and with the lacuna increasing in number and also enlarged. So on the EDI-OCT, you can see that the tumor showed thickening of the RPE in the pigmented area, and in lacuna area showed RPE atrophy. Malignant transformation is very, very rare. Only one case report has been in PubMed search has been found. Choroidal metastasis is the next most common tumors that we found. If the patient comes with bilateral tumor, it's very easy to diagnose. But sometimes, if the patient comes with only unilateral tumor, it may be difficult. On ultrasound, you may see the pancake or platter shape of the tumor with variable internal reflectivity inside the tumor. This patient has unilateral a melanotic mass, which was found to have to be choroidal metastasis from breast carcinoma. You can see that the tumor has orange pigment, like in melanoma, has subretinal fluids, it's the same, but on OCT, the surface of the OCT may be a little bit wavy, not like dome shape in melanoma, which was treated successfully with chemotherapy. So in the large series by Shields, show that the most common site of uveal metastasis is choroid, whereas the breast cancer and lung cancer is the most common. Only 66% of the patient has history of cancer at the time of diagnosis. And most of the patient has unilateral and unifocal tumor, which make it difficult to differentiate from melanoma, but tends to be yellow in color and has platter shape on ultrasound. Mushroom shape found in 2 patients only with very large tumor. So still you can find mushroom shape in metastasis. So enhanced depth imaging OCT can be helpful in diagnosing of choroidal metastasis, whereas the lumpy bumpy of the anterior contour of surface has been found in 64% of the tumor, comparing to melanoma. Usually it's the dome shape. Choroidal hemangioma is quite common. The lesion appears as the very red-orange in color, so it it's different from melanoma. If the patient has Serge-Weber syndrome, then they might guide you for the diagnosis. Sometimes RPE hypertrophy or hyperplasia can be found overlying the tumor, making it look like melanoma. On the ultrasound, it will show high internal reflectivity, and on ICG is a hero in the diagnosis, because this is the only one tumor which produces early hyperfluorescence on early ICG and late washout. Our report has shown that EDI-OCT is helpful also in the diagnosing of choroidal hemangioma, because 100% of the patient has smooth anterior tumor surface contour with no capillaries, choriocapillaries compression. Comparing to nevus, melanoma, or metastasis, they all have the choriocapillaries compression due to the solid of the tumor. But choroidal hemangioma is the enlargement of the vascular channel, so you don't see the compression, but rather you see the expansion of medium and large size choroidal vessels. Vasoproliferative tumor is very interesting. We found this more than we think. So it's a vascular tumor of the retina, which would show very bright fluorescence in fluorescein angiography. This is the patient treated successfully with IVTA and cryotherapy. You can see that the massive subretinal exudates disappear after the treatment. This is one of the key to differentiating it from melanoma. PHCR is very common. It's the bleeding and exudate underneath the retina in the peripheral area. So sometimes if the bleeding is so high, it can simulate melanoma. But on fluorescein angiography, you will see the blockage of the fluorescence due to subretinal hemorrhage. And if you follow the lesion, it will disappear eventually. Usually it happens in female, in peripheral area, and the contralateral eye, you might see the drusen. Optic disc melanoma is the pigmented tumor over the optic nerve. It can produce vitreous pigment, and it can show enlargement. This is our patient we don't have a 16 years follow-up as Dr. Goto, but with 8 years, we found that the tumor growth. So from the series, 10 years of enlargement has been found in almost 1/3 of the patient, and malignant transformation is quite rare. But visual field analysis is crucial because you have to see they can have the visual field defect. Choroidal osteoma is the melanotic tumor that happens in our series. So 50%, almost 50% of the patients showed this growth, decalcification, or visual loss during the 10 years follow-up. So if we okay, so with choroidal osteoma, the key of differentiating it from melanoma is to do the ultrasound. You can see the shadow of the calcification. So after all these tumors, now you know that we have the tools, many tools, clinical examination to differentiating these lesions from melanoma. And it's very crucial to early detect melanoma for better treatment outcome and patient's prognosis. If in doubt, sometimes fine needle aspiration biopsy can be performed to confirm the diagnosis. Thank you very much.
Thank you. Any question from the audience? I have one question, quick question. Do you have any experience of the patient who developed melanoma from the hypertrophy of RPE?
I don't, but
How about you?
Yeah, so we have not seen congenital hypertrophy of the RPE develop into melanoma, but we've seen it develop into adenoma and adenocarcinoma. So even though these tumors, these congenital birthmarks, tend to remain stable for life, they might enlarge a little bit. I always tell the patients we need to keep an eye on it because there's a less than 1% risk it can transform into an adenoma or an adenocarcinoma. Jared, do you have a comment on that?
No, I agree completely. I agree completely. We follow a lot of these patients for years and they stay stable, but one thing that we did find is that, and the Grofus is a group as well, congenital hypertrophy of the RPE will show growth on serial photographs in 80% of the time. And that makes people suspicious for malignancy, but we've not yet found a malignant case leading into melanoma. It's just adenocarcinoma. And the adenocarcinomas do not have a tendency to metastasize. Even though they're carcinomas, they stay stable.
Thank you for your comment. So next speaker is Dr.